We're going to go ahead and get started. Welcome everyone. My name is Corey Lubring, and I am the PBRN coordinator at DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let us take a moment for the housekeeping rules of the webinar. First, please feel free to introduce yourself in the chat and tell us where you are from. We also invite everyone to turn their cameras on so we can be united as an OMM research community. Second, if you have any technical issues during the webinar, please put a message in the chat. Third, if you have any questions or comments during the presentation, please feel free to type them into the chat and address each other's questions and comments there as well. Also, we will have time for discussion and questions at the end of the presentation. And last, please keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. Today is our Let's Talk About OMM Research Journal Club, entitled The Relationship Between Osteopathic Manipulative Treatment and Focused Breathwork, a Pilot Study with Dr. Amy Dean. And Dr. Dean is an osteopathic neuromusculoskeletal hospitalist at Mercy Health in Muskegon, Michigan. I apologize if I mispronounced that. I'm not a northerner. And serves as core faculty for the ONMM post-residency training program there. She is also the adjunct faculty for Michigan State University College of Osteopathic Medicine. Dr. Dean completed her medical education at ATSU in Kirksville, Missouri, and completed her internal medicine residency at St. John's Detroit Riverview Hospital and her ONMM residency at Mercy Health. Her clinical and research interests include OMM treatment of adults and newborns in their inpatient setting, using OMT to improve stroke patient outcomes in the inpatient setting, and cranial osteopathy. So please help us welcome Dr. Amy Dean.
Thank you for having me today. I appreciate this opportunity, and I hopefully we can have a great discussion toward the end. I think this article brought up some questions for me and just some things to think about, and that I think I'd like to have some meaningful conversation about. So this article was actually done, let's see, next slide, by medical students. So it was third and fourth year medical students that actually tackled this pilot study, which I thought was pretty impressive, because being core faculty for residency, it's really hard just to get a case study onto a poster. So the fact that medical students took the time to do research, osteopathic research, I thought was really impressive and deserved to be recognized and talked about. Next slide. Why this article? So I always feel like osteopathic research should help us understand how we can improve patient outcomes. So working in the hospital or even in the clinic, I think that's the thing that probably is most important to a lot of us, is how do we get patients better? How do we help our treatments last longer? And this starts to kind of delve into that, using breath work to kind of augment the length of time that somatic dysfunction is resolved. And also because it talks about OMM and the breath, and that concept goes back to the beginning of our roots, of our lineage. I thought it was important for that reason. And as I discussed before, it's an article that addresses student-based research, which we really need more of, and we really need our students to understand research principles better, because they're being asked to do projects for ACGME and residencies. So I thought that was a good reason. And the last one is kind of a recent choice of why this article is this whole concept of effect size, which I didn't really understand. And I have to thank Jane Johnson. She took some time yesterday to help me understand this principle and why it's important. And we'll talk about that later, but it's basically a way to assess and plan for future study sample sizes. And on that note, I think a lot of us who are interested in OMM research and who are doing OMM in general, oftentimes are questioned about our sample size studies. And this effect size is a way to predict sample size for future studies. So I think it's an important concept. And I also think that in a way, we're too hard on ourselves for our sample sizes. I don't know if any of you read the spine literature, but there have been studies done on posterior, anterior lumbar fusions, and kind of to set guidelines for those. And some of their ends are 45. So I really feel like we should keep doing research and keep being interested, but I think we should be proud of ourselves because, you know, we are doing the research, and neurosurgeons are doing studies with ends of 45 and setting guidelines. And I think we really need to realize that we're pretty awesome and what we do is awesome. And we just need to keep doing the research and keep doing the work to show what we do works. So, and that's the end of my soapbox for that. But anyway, on to the next slide. And Corey, I might ask you kind of periodically what slide we're on, because I'm reading off my PowerPoint. Are we on the Andrew Still slide?
Yes, sorry, yes.
Thanks. Okay. So just briefly, what I mentioned earlier is just talking about OMM and the breath. And this concept goes back to the beginning of osteopathy, and in Still's philosophy of osteopathy, he had a whole chapter on the diaphragm. And one of the sentences that I think is important, that's often maybe not talked about as much as he has a quote that's roughly, you know, by the diaphragm we live and by the diaphragm we die. But this one, I think, speaks more to us clinically. He says, the diaphragm is possibly the least understood as being the cause of more diseases when its supports are not all in line and in normal position than any other part of the body. So just thinking clinically about OMM and breathing and how this impacts a lot of different disease processes that our patients are having. And it is an important concept. And I can't talk about OMM and breath work without mentioning Dr. Fulford. And I know Dr. Brooks worked with Dr. Fulford and would have a lot more knowledge and a lot more to say about him than I do. So I have a limited knowledge, but Dr. Fulford always incorporated breath work into patient care, and we give homework exercises. And these are in the back of his book as well, Dr. Fulford's Touch of Life. And just as a way to kind of reignite the body to help keep alignment and to promote healing. So, and starting to talk about the study here, the purpose of the study is that it was, that's the next slide, designed to consider effects of sample sizes on statistical significance of outcomes for future studies, and also to learn the effect size needed to gain significant results in future prospective studies regarding OMM and breath work, looking at peak flow, thoracoabdominal range of motion, and somatic dysfunction. And also the purpose of the study was comparing the impact of OMT and focused breath work on somatic dysfunction. Just quoting from the study, their objective was to investigate the combination of OMT and breathing exercises compared to each group alone, and to see if there was a statistically significant improvement in somatic dysfunction, TROM, and peak flow. In the introduction of the paper, they do discuss how OMT has been shown to improve breathing function, and that breathing exercises have also been shown to improve function of the respiratory system and respiratory disease, and that there is more research needed to examine synergistic relationship between OMT and breathing exercises. Next slide. Looking at the methods section, it was a prospective randomized three-way crossover study. It was a pilot study, the first of its kind, looking at OMT plus breath work and how it affected peak flow, somatic dysfunction, and thoracoabdominal range of motion. And the question of the study is therapeutic, in that results could impact patient outcomes and quality of life. Next slide. Regarding subject selection, the students from the colleges of healthcare professionals were selected from the Doctor of Osteopathic Medical students and physician assistant program students. And I couldn't tell, I'm assuming it was not a multi-center, that it was one campus, but I wasn't clear from the paper about the study site. They began with 63 subjects. It was an unfunded study. Next slide. Their inclusion criteria was commitment through the entire study that they were not pregnant, no history of osteoporosis, no fractures, no acute inflammatory disease, no bleeding disorders, no cancer, no acute or symptomatic respiratory illness, such as pneumonia, and no current adjustments to any medications. Next slide. The exclusion criteria that they listed was lack of consent by the subject. Next slide. For their final cohort, they had 35 subjects. They had attrition of 5 subjects, and they had 28 female, 7 male subjects, and they were randomly assigned to 3 groups. So they had breathing exercises, OMT group, or both groups, and it was a 3-way crossover study. Next slide. So I'm going to talk a little bit about effect size, because they start to talk about it, and to me it was a little confusing, which is why I reached out to Jane for help. And she had some, I think, pretty good insight into it for me that I hope I can convey to you accurately. And it's statistical thinking, so I'm hoping that I can articulate this as well as she did, or at least a little bit close to what she said. So this whole concept of effect size is what they were interested in studying, because the effect size can help you determine what number of subjects you need to have statistically significant results in your future studies. So it's a way to look at how big the effect was for a given modality. Did it have a large effect? Did it have no effect? And that's what effect size is doing. It's to statistically detect optimal sample size for future studies. So for the methods, as far as the general osteopathic treatment piece was concerned, it was OMT done every 2 weeks over a 6-week period. And each group switched roles every 2 weeks. And there are 4 data collection sets for each subject. Next slide. And for the OMT protocol, what their concept was, and their goal was, is to reduce the most significant somatic dysfunction within the body as a preventative health measure. So they were endeavoring to treat each of the areas of greatest dysfunction that were associated with primary and secondary respiratory muscles, as well as the anatomic diaphragms. Next slide. They developed a 40-point somatic dysfunction scale, and the authors the 3 authors and examiners put together the scale. It was by consensus. It was a 40-point scale, 10 body regions, and then 5 points per region, so 0 to 4. And the criteria was determined by the examiners. And the somatic dysfunction was assessed for all groups. Next slide. The OMT protocol was performed over a 15 to 20 minute time frame. It was a whole body treatment, and the techniques that they included were myofascial release, muscle energy, balanced ligamentous tension, or LAS, FPR, and still technique. Next slide. The breathing exercises were a combination of 9 different exercises that were being used to recruit abdominal wall, pelvic floor, and the thoraco-abdominal diaphragm. And these were taught to the subjects by demonstration video and written documents. And then at home, the subjects would do 3 days per week, would do the breathing exercises for a 2-week interval for the time that they were in that group. Next slide. And they also examined 3 different measures, which I mentioned earlier: the thoraco-abdominal range of motion, peak expiratory flow, and the somatic dysfunction scale, which we just talked about. Next slide. So for the thoraco-abdominal range of motion, they did a circumference of the thoracic cage that was at the level of the inferior costal margin, and then they did it at the midclavicular line. So during inhalation and exhalation, and then they did a calculation based off of that data to get the TROM. For peak flow, they provided peak flow meters to the subjects, and then as I mentioned earlier, the somatic dysfunction scale they used was the 40-point scale that they developed. Next slide. With the data analysis, it was submitted to anonymous Qualtrics profiles. They had two different sets of data. They had normally distributed data, and for this they used t-test and ANOVA, and then they had not normally distributed data, which they used the Wilcoxon sign rank test. And that apparently has, this is where Jane was helpful, it has more power than the t-test. And she said that sometimes the computer decides what's normal and what's not normal data. So normal data is kind of, you think of that bell curve, and then you can use certain tests. And then if it's not normally distributed, such as the TROM and the somatic dysfunction, then you use other tests. And I thought this was where it got kind of interesting, really, because you have two different sets of statistical tests going for the normally and not normally distributed. So the effect size is a way to be able to compare these different variables in the groups and have it mean something. Next slide. So she had mentioned that effect size is kind of like BMI, would be a similar analogy. So you have different people with lots of different weights, and they have lots of different heights. So if you're looking at their weights and you're not taking their heights into account, it's not as meaningful as if you use the BMI. So the BMI standardizes those different variables by adjusting for height. And then you can make comparisons between people, and it helps the data be more meaningful. It kind of puts things on the same scale. So that's what effect size does. Next slide. It's a common scale that can compare different groups. And this is just a little table of how that works. So if there's a large effect from a treatment, it'll be 0.8 or greater. And this is going to be important when we start looking at that figure 1 that they had in the study, just to help that make more sense. If it had a medium effect on outcomes, it's like 0.5, to 0.7. And if it had a small effect, it's 0.2 or less. Next slide. So effect size also is to determine what kind of sample size do you need for future studies. It gives you an idea of what is needed in the future to statistically detect what is going to be significant. So it helps you plan ahead too. Next slide. So in the results and discussion section, they started talking about how OMT had a bigger effect on somatic dysfunction than peak flow and on TROM. So if you look at these different bars, breathwork and OMT is the blue, and then OMT itself is the pink, and then breathwork alone is the gray part there. So you can see how OMT and breathwork is, that effect size is 0.4395, and that's the largest effect size. So OMT plus breathwork had the largest effect on somatic dysfunction. And then if you look at OMT alone, that was 0.4153. So that also had a fairly significant effect on somatic dysfunction. But if we start looking at OMT and breath work for the thoraco-abdominal range of motion, it's 2.62. So starting to get into the small effect. And then of course you'll see the OMT alone it appears to have had no effect, which is interesting, I think. And then if you look at peak flow, none of the treatments had an effect on peak flow. Those were very small effect sizes. Next slide. So what the authors started discussing is for somatic dysfunction, because the effect size, was the largest here for somatic dysfunction, that in the future studies, that would be larger studies, you would require a smaller population to see statistical significance. But then when you're looking at peak flow, you would need a whole lot larger population to have data that was meaningful there. And the authors did conclude that OMT plus breathwork may have a synergistic effect on improving the incidence of somatic dysfunction compared with OMT alone or breath work alone. Next slide. Oh, and I just said a minute ago, because the effect size is so low with peak flow, it would require a much larger population to have a high enough power to have statistically significant results. So that if you were planning on doing a future study, you would need a much higher subject number. Okay, next slide. So per the authors, the study weaknesses were, and this is something I thought we might want to talk about in the discussion. It was a needs-based protocol. So it was not a technique-driven, strict, repeatable protocol. And I know at past, let's talk about OMM, Dr. Cheritelli was on, he was talking about needs-based protocol versus technique-driven, and that needs-based is more how we practice in the clinic. And it's more of an assessment of kind of the real world, whereas technique-based protocol seems to be more effective if you're evaluating a technique, but not necessarily a clinical situation. So the authors talked about that needs-based protocol being different, and it may have affected the data. And they also noted that there was no effect size for the thoraco-abdominal range of motion. And I assume they meant in the OMM group, but that there seemed to be no improvement in all three groups. And they thought this might be something to do with the breath work coaching, might have something to do with patient performance, because they weren't assessed on it during those 2 weeks. They were just doing the initial training at home. Next slide. The authors also stated as their study strengths that they had controls for inter-examiner variability, and they did a lot of work to establish a rigorous scoring system, this somatic dysfunction scale, as well as trying to control for treatment methods and anatomic regions to be scored. And they also talked about consensus training. And I don't know if Dr. Degenhardt, I think he had mentioned to me when they were doing the MOPSI that there was regular kind of calibrating of the hands, and maybe he can speak to that, to try to maintain some type of consistency with the different examiners and OMT providers. So their conclusion was future studies of OMT and breath exercises could have sample sizes determined by the effect size in this study, and that larger studies could be performed on clinically meaningful effects of OMT and breath work. Okay, thank you.
Hey, Corey, your audio's off.
Aha! Let's try that again. I will just speak into the void. I thank you very much, Dr. A.V. Dean, for that wonderful presentation. So just a few reminders as we open the floor to all attendees for questions and discussion. First, if you would like to speak during the discussion, please raise your emoji hand, which is located at the bottom of the screen under the reactions menu. We ask that you briefly introduce yourself, and please feel free to turn on your camera if you would like. When contributing to the discussion, please limit microphone time to 3 minutes so we can allow everyone who wants to participate in the discussion ample time. We will provide you with a timer to assist with keeping track of time. And after everyone has had the opportunity to make comments or ask questions, there may be additional time for more comments and questions. And third, the moderators will be happy to read any questions or comments. If you would prefer to type them into the chat, please feel free to address each other's questions and comments there as well. And we'll start off. It looks like Jack Westfall has a question or comment.
Hey, Jack Westfall here. I'm a family doctor in Denver, Colorado. Amy, the article is great. The study was great. Your description of it was fantastic. Walking through the effect size was really nice. Thank you.
Thank Jane too.
Thank you, Jane.
Was
Where is
Jane?
Jane?
To me.
Yeah. So thank you, Jane. G and you guys can thank her. One of the things that I'm interested in is that these were all younger, healthier subjects. So there could have been what we call a ceiling effect. That is, they were all doing pretty well. How much better could they get? Like on the peak flow, these are normal people. They have normal peak flows. So you wouldn't expect, which I liked that, because had I seen a big effect on peak flow, I might not have trusted the study as much, because I'd have been like, I don't know, they're all healthy already. This makes you a hyper breather, a super breather. So I liked it. And I think we have to consider that effect size of 0.4, which is in the low to moderate range, is the floor of effect. If we did this very same study with 35 people who were not necessarily young, healthy people, like maybe some of the people on this call, I won't say who, what would the results be? Anyway.
Those are great points. And I hadn't thought about peak flow. I thought, well, they said they gave them peak flow meters, but did they not tell them how to use the peak flow meter? But you're right, they're healthy individuals. So maybe that actually strengthens the data.
I think it strengthens the data. It's clear they weren't faking it, or that you'd have seen a change there as well. If they were trying to make OMT look better or breath exercises look better, you'd have seen an improvement, and you didn't, which means they were given their all. They were really doing a good job. So in my mind, that is one of those sort of balancers where you wouldn't expect a change. And so the fact that you don't see a change strengthens this study, I believe.
And I wonder what your thoughts are, or maybe someone from the group, Dr. Degenhart or someone, about that TROM with the OMT being pretty much non-existent. If that is just calculation, or I didn't know what to make of that on that figure 1.
Well, first of all, I'd like to just echo Jack's comments. Amy, what an awesome job. You found a great article, really pertinent article as well, and did a great job presenting it. And I 100% agree with Jack's comments. You have to look at your sample population in order to determine, what outcomes you can expect. And so their inclusion criteria, right from their inclusion criteria, kind of dictated what the outcomes were likely is going to be.
Right.
And so they found, their somatic dysfunction measure to have, the greatest significance. Well, that will always be criticized because somatic dysfunction is a pretty soft, finding and so forth. And so I wouldn't look at this outcome and saying, well, we need to use this as our future measure. No, we need to find the right population where the more objective measures are going to be more clinically relevant. Okay.
Well said.
So the other thing they said that they talked about, they said needs-based treatment. Just for knowledge sake, over the last 30 plus years, we've called that as pragmatic treatment. We base it on the needs of the individual. So that would be a better term for that.
Good to know.
And one other comment, in Dr. Still's statement, he talked about all of these different diseases being caused by, the diaphragm, and we don't really know, how the diaphragm functions. I would argue that oftentimes in science, causation versus association are confused. And I would say at this stage of our scientific development, we can say pretty confidently there's a large amount of association of where the diaphragm could be contributing to disease processes. And this is something we definitely need to investigate. But to say it's a causation, I think that's more of language of his time and is no longer pertinent in our time. Thank you.
Thanks for sharing that. That's a good point.
There was a comment from Jed Downs just in the chat that stated somatic dysfunctions included all 10 ICD-10 regions. How many third and fourth year students have the skills to treat viscerally?
I think from, I have worked with Ken Lossing a long time, studied with him since the late 90s. And I think from what I can see with the residents that I'm working with and just kind of in general, kind of taking the pulse of things, I don't see a lot of visceral being taught. And I think from what I'm seeing, it is really effective in the hospital, but you have to have that skill set, and you also have to have the right type of patient to use it on. Although I'm sure that, different people who do visceral would say different things. I do think this is a gap in our knowledge gap in our curriculum. I also know that there's probably a huge scientific research gap too, right? So I don't know that it's been studied as much as it should be, or if there's a whole lot. I've looked at the published literature in the past, and I haven't seen a whole lot. I see it work amazingly well in the hospital, but I don't see it in the medical school curriculum. And my understanding is that there is kind of a movement afoot to start to standardize visceral curriculum and to get that into the schools. So I know Dr. Lossing is spearheading that effort, and he's starting to get his kind of core teaching people together to try to get that into the hands of students more.
Kelly Joy, your hand came up next. Oh, you're muted.
Of course I am. Just when I try to impress my colleagues. So I will say, from a perspective of somebody who coordinates first and second year curriculum, we present visceral techniques to the students, but compared to what I've learned in residency and the like, it is very watered down, and trying to find a place where they can actually interact with the information that makes sense. I mean, they're still in the first and second year trying to figure out how to do an abdominal exam that makes sense, and figuring out that there are abdominal viscera that they should be palpating for as part of that exam. Right. That, I think that the handfuls that are interested and engaged could probably walk out and do a third or fourth year study of some use. But I would also argue that the point is well made that the grand majority are still trying to figure out that there's a liver.
Dr. Degenhart?
Point.
Yeah, so Amy had brought up the MOPSI study and just how we try to deal with the training of the people providing the treatments. And during that study, it was a 3-year study, took place at 7 different hospital sites, and we had 81 people involved in the treatment. So we thought this is the most complicated study to date. And so we went 3 times a year to each site, and we brought instrumentation along to try to help, assure consistency in the treatment process. And I would have to say, unfortunately, I don't feel that was adequate with the number of treaters that were involved in that study to give me a lot of confidence that we optimize the potential OMT effect as they did that particular study. In regards to the one measurement where they look at the circumference of the belly at inspiration and expiration, we've been working now several years to better evaluate trunk mechanics during breathing. And that has been considered often the gold standard, but it's a gold standard that is really pretty rusty instead of gold, because the stability of holding, the measurement tape right and getting it from the same location and repetition and so forth, it is not a great outcome measure in and of itself. So it is something that they are now looking at CT and MRI scans as a way of trying to characterize rib cage motion and so forth. of which you could imagine is very costly and not very practical. And there are some other groups, and our group here at ATSU is probably leading in getting the most refined tools as an outcome measure for looking at diaphragmatic and rib cage motion. So the fact that we didn't see a lot there in this situation is because the current state of the art, the measurement isn't as good as we need it to be, and we still need to continue in developing better ones.
All right. Jed Downs? Oh, you're muted.
No, and again, with regards to breathing, I mean, one can take a maximal breath, and if you played around with your breathing, through your life and through your training, you realize that you can breathe maximally into your chest, maximally, down towards your pelvic floor, maximally sideways. So you can control that maximum breath to a degree. And I imagine there's some difference in consistency. Somebody who's been a dancer is going to breathe laterally, as opposed to, in some other direction. Other people, they think that deep breath and they put all their neck muscles and stuff into it. So, I mean, I would be interested in I don't know what the breathing exercise coaching included, but, a standard method of breathing is probably even in question.
I wondered about that too when I read the study, and I noticed there were some, just basic abdominal breathwork publications that were looking at significant lowering of cortisol and things. And that's one thing I wondered about, if they could have picked like something that had been shown to be, statistically significantly beneficial in the published literature, versus like 9 different ones that, maybe there was some difficulty in kind of either completing those or, in knowing what to do exactly to kind of make it more simplify the breathing for the subjects.
Yes, Dr. Dagenhart.
Sorry, I got a lot to say today. Design of an excellent study. It's probably the best student study I've ever seen, and it's probably in the top 90% of any work that I've seen. They did an awesome job, so I'm glad that you identified it, Amy. One thing I want people to think about, and you're getting kind of an early information, because this is going to come out hopefully in the next foundation's text, is when we think about our sample and our inclusion criteria, we never really think about the patient's history or their somatic dysfunction themselves. And so you have people that might be young, basically considered normal. They may have been in a car accident that has resulted in some chest blunt trauma. They're going to be an entirely different population than what we consider normal. So it may be in our future that we not only think about their symptoms, but actually as our exam skills improve and become more reliable, that actually inclusion criteria looks at the patient's history as well as the dysfunctions that you've identified in that person. So we look at those that have more clearly dysfunctions in the rib cage, in the trunk, in the thoracic spine, and so forth, as part of the criteria for identifying our population.
Yes, Kate.
Hi, I couldn't make the little hand work, sorry. So thanks, Amy. That was awesome. I love the article. I guess what I'm wondering is if our floor, as Jack said, for this is treatment for OMT is around 0.4, 0.5. We're having a medium effect, at least in that population. Anticipating we would have a higher effect. How does that get us to that equation to say what our N needs to be to have a medium effect? How many people do we need to have in a population to be able to show that medium effect?
I think that's a great question. And I don't have a clear handle on the statistics. And it sounded like from when I talked with Jane that there is kind of a whole way using math and square roots and things to kind of determine what that would be. And I don't know what the mechanics are, or the math is to get to that information. And I don't know if that's something she could talk about maybe when it gets posted in a discussion section, or maybe somebody else knows. But yeah, I think it's a great question. I would love to know the answer to that.
Jed Downs?
Yeah, when Brian was talking about people's past history and stuff, it brought to mind issues with regards to health equity and racial differences. When I was going through my training, Black individuals were considered to have lung capacities that were about 15% less than white individuals, but that did nothing to take into account the fact that they were probably growing up in much more hazardous environments, would have been exposed to a lot more particulates and so forth as time goes on. And so even that kind of those environmental factors might make a difference in terms of what your potential to improve somebody's function is.
That's a great point. I think you're right. That I don't think that's broken out in the data as much as it should be and would be helpful to a lot of people.
Dr. Degenhart?
Yeah, I think when we have our power analyses, our effect size as a way of trying to predict what our next study needs to be. And without a doubt, I want to say that this study, should be empowering and challenging the profession to have follow-up studies, because, this is just that important. And this is how science works. But when we look at science in general, and we look at the reproducibility of one study to the next, it is not as high as we think it should be in science. A lot of times we can't reproduce outcomes of one study to another study. And in my, just from my more recent study, I am concerned that when we think about inclusion criteria, we have very, very kind of broad buckets for determining what that criteria is to describe that cohort. And I can almost guarantee when we go from one study to the next, that those cohorts aren't necessarily as identical as we think they are. And so identifying more refined, and I bet if Jane was here, she would be willing to have a dialogue on this, because I'm creating more work for her, and as a result, it narrows down the potential of people that might fall into those buckets. But you have, let's say, a population that just by chance, let's take a mind, body, spirit example, that are more anxious, may have had more non-physical trauma and its influence on the diaphragm and the ability to take a deep breath and so forth. I mean, very, very different population than, people that have not been exposed to those environmental factors in the past. So if we're dealing with breath work and that type of phenomenon as an outcome measure, maybe once again, we got to think more precisely about what factors we want to use as part of our inclusion criteria. Because if somebody is anxious, they just always feel like they got a fist in their gut because of what they may have experienced, even the best OMT in and of itself from a biomechanical model isn't going to be, the solution for that person. So some further things to consider.
All right. Anybody else have any more comments or questions they would like to add? Yes, Jen?
Why not? We got a little bit of time left. One thing that was in question for me as I read the study was, okay, we had this triple crossover pattern, and once you've done the treatment for somatic dysfunction, any future effect might be taken care of, because if the somatic dysfunctions don't come back, then you're not going to pick up any more impact, except, from beginning to end, so the timing of the somatic dysfunction treatment was confusing for me. I mean, so you could do breath work, you could do breath work in OMT, and you could do OMT. So you're gonna be in each of those groups. So you got 4 weeks of OMT, 4 weeks of breath work, and so being able to see cutoffs between which intervention was having the most effect. I guess it would seem to get watered down if everybody had all the same treatments. Okay, that's all I was going to say there. What was my other point?
I didn't know if you saw it. There was a little on the bottom of page 15, and I don't know if this answers your question. It says that they use the ANCOVA test to determine if the order in which subjects participated in each group had any effect on the data results. And they gave 3 different p-values for each, peak flow, TROM, and somatic dysfunction scale, and none of them reached statistical significance. So they said that allowed them to examine the groups individually. So I don't know if that answers your question, or maybe.
I had statistics in 1988. It isn't here anymore.
Ditto. I think I had them in the early 90s, and I don't know. There's a little bit in there somewhere, but lots of cobwebs.
Kelly has her hand up, and then we'll go to Kate as our final question comment. Oh, you're muted again, Kelly.
My question was, did they specifically tell the patients to stop doing breathing exercises when they moved on to the next part? Or did they have any way to say, like, okay, this person, tripped over something and had somebody pop their back during the next couple of weeks or something like that? I just kind of wondered, like, was there any bleed over from that perspective, and would that affect the study?
I think that's a great point. I don't see anything in their discussion that indicated that, or the results, but I think those are really good questions too, that that should be addressed.
Okay.
Yeah, just on the comment on that, I think if it did have an effect, if they were breathing and doing OMT, then that the breathing group would have looked more like the combo group, I would think. And it didn't. So my last comment was, does anybody know these folks down in Tennessee? And has anybody talked to them to see about, 1, are they doing this with a more symptomatic group? And 2, is this something that would make sense at all for DO-Touch.NET to have a bigger N to do something like this to along with it? I know it doesn't go along with the card study idea, but it's pretty elegant.
Comment on that, Dr. Degenhart?
I do. Thanks, Kate. Great question. Great challenge. As I was listening to it and saying, yeah, we need to follow up with that. It would be one of those Herculean studies for us to do it in a practice-based research network. It's not one that I mean, I'd be excited to have it done. The issue is, just from our history, we like to take on big projects. And so I know it probably wouldn't be finished in my lifetime. So to get it done, but at some point in time, I would like to reach out to this research group and definitely encourage some follow-up. I'm going to actually encourage them to also present this for the RPM grand rounds at the Academy meeting as a way of looking at where their next step would be and how we might be able to pull together, infrastructure to support them with that. So thank you for bringing that up. That brought up a great an idea. So I will take that on to reach out to them.
That's great. Thank you.
Great.
All right. Well, sorry, did you have something you want to say, Amy? I saw your mic light up there.
Oh, no. I just thought that was a great idea. I'd love to see next steps with this too. I know Herculean indeed, but it'd be pretty awesome.
Well, unfortunately, our live discussion time is up. So don't forget that this webinar recording will be placed on the DO-Touch.NET YouTube channel, where we can continue this discussion. Watch your email for an announcement when that recording is available. And thank you again, Dr. Amy Dean, for this wonderful presentation. Our next episode of Let's Talk About OMM Research will be a network update, and there's a date change for that. It will be on October 27th, so the last Friday of the month rather than the third Friday, due to conflicts with conferences and Founders Week and such. And that will be with Dr. Brian Degenhardt. So we look forward to seeing everybody then.